Dr. Milind, happy to have you here. Welcome, sir. So I think I don't have to talk much about you. A lot of people already know you. I was talking to a lot of people, and they said that yes, they have read this paper, that papers in our medical oncology fraternity. But I would definitely want to know that a part of you was spent in India, then you decided to go to US, and then to medical oncology to choose as your specialization, and then followed by the micro specialization in pancreatic or biliary cancers. So, what was the thought process behind this journey? First, we'll discuss that, and then we'll take this forward.
I grew up in Mumbai, and
Okay.
I went to Grand Medical College. I was exposed to oncology, even including in my own family. And I remember one particular instance that really kind of struck me was in medical school, we used to read this textbook called Love and Bailey Textbook of Surgery.
Yes,
And
yes.
in that, we were reading about gallstones, and one of the what was taught was if there's a gallstone in the liver, in the gallbladder, and the patient has no symptom, there's no indication for doing anything. We call asymptomatic cholelithiasis. So one of my good friends, he was from Punjab, and his mother had that situation, and then she was seen on sonogram, and then they found this gallstone, and then unfortunately, although she was getting good medical care, a few years later she had gallbladder cancer, and the gallbladder cancer was not treatable. She died. It got me interested in oncology. I realized that there's a great knowledge gap in how we diagnose patients, how we treat patients, how we treat patients in overseas, and how we treat patients in India. So I did at that time when I graduated, there was really no DNB or DM or things like that in oncology in India. So I decided to go to the US and I studied over there, and I did my fellowship in oncology at Roswell Park. And I was really attracted to trying to answer the more difficult questions, to go for areas that people thought were hopeless. In other words, situations that had a very poor prognosis. Because I think that's what attracts, you're an oncologist yourself. So, that sort of attracts people like us into the field because there's so much work to be done. And I wanted to be a part of that journey. So that's sort of how I got into oncology. While in oncology, I realized that there were some areas, the pancreas, biliary tract cancer, and so on, which were sort of the orphan amongst orphans. Even they had an even worse outcome than the traditional cancers. So that's one of the reasons I really wanted to get into those specialties.
Yes. So I get it, but still, I would say it was a brave decision because yes, like you use the term hopeless cancers. So there are multiple myths surrounding cancers, and people think it's a death sentence. And also I think also because the pancreatic cancer and the gallbladder cancers, even with early stages, because they are diagnosed in an advanced cancers, and so the mortality rates are high. So, just to focus that we are going to discuss today about the pancreatic or biliary and the liver cancer. So that means the pancreatic cancer starting from the pancreas, bile ducts cancer. I'm not sure if many of us are aware in the audience, and I would definitely want Dr. Milind to explain what are bile duct cancers. We'll be also discussing the gallbladder cancers, which are very common in India, especially the Indo-Gangetic belt, that is the area of Uttar Pradesh, Bihar, some parts of Haryana, Delhi, and West Bengal's huge numbers of gallbladder cancers that we have here, highest in the world. So we'll be discussing something about that, and we'll also take few things about the liver cancers. So, Dr. Milind, just a word about the bile duct cancers because I think there's a lot of lack of familiarity, and then maybe we'll take one by one starting with the risk factors.
Sure. So I want to clarify these cancers, Priya, were thought of as hopeless. I don't want the audience to think today that these are hopeless anymore because
Yes,
there's a
that's
lot
right
that we
word.
can do.
Yes,
Okay,
nice
there's a
statement.
lot that we can do.
Mhm.
So, in terms of bile ducts, so the liver, I explain to patients, is like a detoxifying machine of our body. So, what we eat, what we're exposed to, the toxins go through the blood and they get filtered in the liver. Then, once they get filtered, they pass through the plumbing, which is the bile ducts from the liver into the intestine. So these bile ducts or this plumbing of the liver is exposed to a lot of toxins and they can therefore get cancer. Gallbladder is a little flask along the pathway from the liver to the intestine. So the bile gets stored into that flask, and then each time we eat, it pumps a little bit of bile into the intestine. So again, the gallbladder is also exposed to a lot of toxins because it's a detoxifying mechanism. So you can get cancers along this route, along the bile ducts and the gallbladder, and they're in some ways interrelated.
Yes. So the whole idea is that the people should understand that the cancers are not just a result of some acute insult. They happen because of the persistent and long-term exposure or the insults. And as you rightly use the term toxins, the pancreatico, biliary, and the liver system are very much important part of detoxifying mechanisms. And in the process, they are constantly exposed to various what we call as the carcinogens, which are actually like the cancer-causing agents, to put it very simply. And that is from where these cancers arise. So that brings us to a very important questions. We see cancers rising with age because I think the cumulative exposure of these toxins increases, causing damages to the cells and in turn leading to damages on the DNA material, the genetic material, and that in turn lead to propagation of cancers. So other than aging, Dr. Milind, what do you think are the other risk factors for these cancers?
So one of the big risk factors, Priya, is obesity. Unfortunately, there's a worldwide epidemic where as we are all getting fatter, it causes fatty liver and fat deposition, two changes in the liver, non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, which is fat deposition and fat deposition that leads to inflammation. So that is really the most common. But there are several other toxins, such as alcohol. There is exposure to heavy metals, exposure in some places to chemicals as during in the workplace. I see some, for instance, in the U.S., veterans who have been in Vietnam who have been exposed to toxic exposure to like Agent Orange, agents that were used in war. So there are many such exposures that may be in the food, maybe in industry, maybe in the environment, and not and least but not the least, just based on what we eat and fatty liver that lead to inflammation and in some cases cancer.
So I think you have summed it up very nicely, but I think for many of our folks, it must be really surprising to hear that even obesity can cause cancer. People think that obesity can cause heart attack, maybe hypertension, maybe diabetes, but cancer is something they think that is something which is very new. And the problem is India is actually going to become the obesity capital of the world, and we have the problem of childhood obesity also. So obesity can cause cancers because I think it can cause inflammation in the body and it can damage cells in long run, all these inflammatory mediators. And liver cancers and other cancers are the important problems that we face because of obesity. Important thing about alcohol, Dr. Milind. So there's a lot of talk that the alcohol in moderation, maybe, I don't know, maybe the French propagated it, but alcohol in moderation is safe. What are your thoughts on that?
So I would say, Priya, that it is a controversial issue. There
Okay.
was some talk in the past, as you know, that red wine may be good for the
Yes.
heart and so on. The reality is that overconsumption of anything, including alcohol, if you
Okay.
compare it with like cigarette smoking,
Okay.
uh, we wouldn't, for instance, accept that, say, one pack of cigarettes a week is fine. We would
Okay.
normally say that's not a good idea.
Yes.
But it's sort of roughly equivalent to one bottle of wine a week, which most
Okay.
people would say is not a heavy consumption of wine. So
Hmm.
I do think that, yes, while we talk of heavy consumption of alcohol being associated with liver disease, less is known or appreciated that even moderate consumption is actually deleterious.
Hmm.
So I don't think I can personally advocate moderate consumption of alcohol.
Yes.
I think we are learning about alcohol, and I think unfortunately with time we will find that it is just as harmful as other toxins that we are more aware of, like smoking.
Agreed. And I think so also because we now know that the alcohol weakens body immunity. And we are also now knowing that realize that the body's immunity is also one of the line of defense against the cancers, not just infections. isn't it? That's a very important
Yeah.
thought that I wanted to understand is what about the role of insecticides, fertilizers, and the pesticides? Like you said, these are the cancers which are, the organs, they play an active part in the filtering or the detoxifying mechanisms. So do you feel that the kind of food that we eat is there's just a whole food revolution going on because of the fertilizers, the insecticide, and the pesticide have played a big role? Do you feel that they also might be contributing to these cancers?
Definitely. Without giving names, I can tell you there were some herbicides used for
Okay.
weed killers used in the West very commonly, and even I used it when I first came to the US to kill weeds. They have been very strongly linked now with cancer. So I think because eventually these sort of herbicides and pesticides get into the water, get into the food and our fruits and vegetables, and they cause these heavy metals and toxins to accumulate in our body. So I do think it's important that we eat the right kinds of fruits and vegetables, wash them thoroughly, make sure we know how what type of agriculture is involved. And I'm very proud that now even in India there are sources where you can trace the origin of the grain and the fruits and vegetables, so you can actually have some idea of what you're consuming. So clearly, while these fertilizers and herbicides have increased our agricultural output, I have no doubt in my mind that they have somewhat also contributed to this cancer risk.
Yes, and also in the if we're talking about that, for gallbladder cancers, especially there is some research going on in India. We were just discussing about the Gangetic Belt. They use mustard oil as a cooking source, and there's a lot of contaminated sources of mustard oil also being sold. And it's like the contamination, what we call as the milavati, this mustard oil might be also contributing to the increased risk of gallbladder cancers. So yes, it's very wise. But the one has to decide very wisely that from where what particular food source you are using, the oil source that you are using also maybe.
Yeah.
And I think that is why there's just a lot of emphasis on the organic farming and the organic food sources. People are just moving towards those kinds. And I think it's the same trend in the US as well, isn't it?
Yeah, so I mean, gallbladder cancer is really kind of an issue close to my heart because unfortunately it affects Indians disproportionately, and young women, who are often affected with this cancer. So I have to tell you that it is certainly more common in North India, like the Indo-Gangetic Belt, like you said. But in the US, I see patients from that part of the world. For instance, in Pakistan. In Pakistan, in women, it is the second most common cancer,
Hmm.
right? So it's not the Gangetic Belt. It's sort of it's also within the area. Afghanistan, Iran. So I think there are some factors which are related to ethnicity, which are
Yes.
related to racial predisposition. On the other hand, in the southern part of India, when I go to other places there, Vellore and Chennai, etc., gallbladder cancer is actually very rare.
Yes.
So it is something to do with, yes, could be something to do with the foods we eat, but I think there is also a relationship with ethnicity and gender, more common in women than in males. Um, and in other parts of the world, for instance, gallbladder cancer is seen in East Asia, Korea, Japan, in Latin America, like the country of Chile, where we have a lot of collaboration, the one of the highest incidences in the world. So there are these strange geographic pockets of gallbladder cancer, which we don't completely understand, but are related to underlying racial predisposition to this cancer.
So I agree completely. There's so much to learn about cancers, and I think even for risk factors, there's just so much to know about it. So that brings us to a very important discussion. Actually, two parts of it. One is I think gallbladder cancers are also caused by the gallstones, and gallstones are simply just so common. You get an ultrasound and there'll be just gallstone. You get an ultrasound, there'll be gallstones. And people often ask, should we remove all those gallbladders? The traditional teaching says no. I think you just touched upon it in the starting. But what are your thoughts? Should we remove gallbladders wherever we see gallstone, whether it's causing any symptom or not?
So at this time, Priya, what we know is that there is a correlation between the size of the gallstone
Okay.
and the cancer. For
Yeah.
instance, if you take patients who have cholecystectomy for gallbladder cancer, or patients who have had cholecystectomy and have incidentally found to have gallbladder cancer, 40% of them have gallstones that are more than 3 centimeters in diameter. Whereas if you do cholecystectomy in the absence of in the absence of cancer, the likelihood of large gallstones is much lower. It's less than 10%. So is there a clear etiology? No, but there's an association between large gallstones and gallbladder cancer. So in practice, if somebody asks me this question, I think I try to educate them on the data. I don't think we can advocate wide scale cholecystectomy for everybody, right? Because as many as 10% of the population who are middle aged will have gallstones.
Yes.
And there's only about 25,000 gallbladder cancer patients in India. So you can't, do millions of cholecystectomies for that reason. But I think we can educate the patients about the risk. We can follow them closely. And cholecystectomy, we can offer them, when we do offer cholecystectomy, it has to be done in a safe manner. So if cholecystectomy is not a big operation, but it does have risk of common bile duct injury, of biliary strictures, and so on. So I think we have to create a cadre of surgeons who can offer that with very, very low morbidity and mortality. And that may or may not exist in India. Until that happens, we cannot widely advocate that procedure.
Agreed.
The last point I want to make is in the West, gallbladder cancer is largely a dying disease. And if you see the association between the number of cholecystectomies over time and gallbladder cancer, there's an inverse relation. So as the number of cholecystectomies have gone up in the population, the number of gallbladder cancers have gone down. So clearly there is some association. But we are a large country in India, and we got to make sure that we know some risk factors. We offer a therapy that is going to be safe before we advocate it.
I think that's a very right statement. And you also highlighted a very important point that sometimes when the gallbladder stones are operated upon, they find cancers there. The term was like the incidentally detected gallbladder cancers. And Dr. Milind, just to inform you, sometimes what happens, we see that whenever the gallbladders are removed, there are parts in India where actually the specimen is not sent to the lab. So the whole idea is to get the sample out, send it to the lab, examine it under the microscope, find out if there is any cancer or not, and if you find any cancer, you have to treat it accordingly on the lines of cancer. It's not just this, you don't have to stop at the simple surgeries. But in India, at many centers, still, especially in the tier 3 cities, in the smaller hospitals, they just discard the sample without properly examining it. And we now know that around 1% of these specimens will have cancers. So the whole idea about this discussion is that the patients can also, that the part of education is also that you have to become aware and remember that yes, a subset of gallbladder being removed for non-cancerous reason might harbor some areas of cancers, and that is why it's very important that even if you're not doctor is not doing it, maybe you can ask the doctors to get the specimen or the sample examined for any cancer. So
Well, that's a very important point, Priya, because actually in the US, the most common presentation of gallbladder cancer is asymptomatic
yes.
incidental finding at cholecystectomy, right? So if we are sending these patients for surgery and then not looking at the specimen,
Yes.
then that would be doing them a disservice. But
Yes.
I think through these sort of programs where you can educate,
Yes.
we will change. There's so much progress has been achieved in our country. So I think this disease, gallbladder cancer, really there is a possibility that it can become history, that it can
Yes.
go down dramatically, even in our lifetime. But we need some simple measures, like you described, to be in place, like looking at pathology, for instance.
Yes. And especially it's very important because we understand that gallbladder is an organ which is like just situated below liver. So symptoms of the cancer are usually masked, and that's the reason that the gallbladder it's hiding, the symptoms are not there. And then when it goes to the liver via various channels, including the bloodstream, when it becomes what we call a stage 4, and unfortunately, then the patient will have the symptoms because of the liver involvement, And then the symptoms will come, then the patient will come, but unfortunately by that time this disease has progressed where we can just treat it and not cure it. But yeah, I also wanted to discuss about a very important aspects about the risk factors, and you rightly said about the ethnicity, as you pointed out. And because the cancers are a big stigma in this part of the world, we have families, the marriages, the bond, the marriages, if the matches, the what we say is that if somebody decides to get married in a family, but if there's a family history of cancers, people will usually break that match. There's so much of a stigma regarding cancers. So how much of the role of genetics in these cancers, or the role of family history or the genetic syndromes?
So, Priya, first of all, I mean, what you described just breaks my heart that somebody would not get married because of cancer in the family.
The stigma is
But
too much.
but I think the gallbladder cancer is not a genetic disease. There is a syndrome of familial cholelithiasis where people have gallstones in the family. There may be a higher risk somewhat in the cancer, but it is not a transmission like, for instance,
Okay.
in breast and
It's a big
ovarian cancer.
relief.
Yes, there is a higher risk. We looked at a sample of gallbladder cancer patients, and we do find there's somewhat higher risk, a higher incidence of DNA damage repair mutations like BRCA, ATM, and so on in gallbladder cancer and biliary tract cancer patients. But it's still a very small number. Most of them are sporadic.
I think in pancreatic cancers too.
And definitely in pancreas cancer, right? Much
Pancreatic
higher
cancer,
in pancreas
the
cancer.
pancreatic cancers. So it's very important to understand the roles of genes and the genetic syndrome. So by genetic syndrome, just to explain to our audience that sometimes there are certain genetic defects which predispose for increased causation of cancers that we see, that are pointed out by like the familiar clustering of certain cancers presenting at young age, and more than one cancer sometimes seen in an individual. So because there are certain genetic defects which can be transmitted from one generation to the another, so that is what we mean by the genetic predisposition or the genetic syndromes. We see more commonly in the breast cancer or the ovarian cancers, but already said by Dr. Milind, also to some extent in small percentage of pancreatic cancer, but yes, not so much in the gallbladder cancers. So
Yeah,
Dr. Milind, that yes.
I'm sorry, Priya, you were talking about genetics, and I also want to make the point that we have studied the genetics of cancers, including gallbladder cancer, quite extensively in the West. Not a lot is known about genetics of this cancer in the Indian population. So we need young people like you and others to really dive deep and look into the genetic underpinnings of gallbladder cancer, pancreas cancer, and other cancers in India, because the genetic makeup of these cancers often differs. We did a study, for instance, with MD Anderson, compared it with biliary cancer patients from Shanghai, China. There were a different set of genes. The frequency distribution was very different. So I think these have implications for treatment, and we need to learn more about the cancers that occur in the Indian population in the genetics.
So I think now the research in India is heading in the right direction. Maybe I won't say at right pace, but yes, it is picking up. And yes, why not? We have to actually, because especially for the gallbladder cancers, we are seeing that the numbers are very high, and that is why we need to find out what are the predisposing factors, what are the genes which are causing, so that we can target them in a better way in future, isn't it? Um,
Absolutely.
yes.
The
So
answers to this type of cancer should be coming from people like you in India, because this is a problem in India.
yes, sir. We are also in the process of writing our own set of guidelines for the gallbladder cancers, because especially for the various treatment aspects, and we feel that maybe we can answer few questions better. So many Indian centers have actually collaborated in starting writing their own guidelines for the gallbladder cancers. So yes, and why not to take forward the research as well? So that brings us to a very important next point of discussion about how to detect these cancers early. So just a brief about, or maybe in the detail, I don't mind, about the symptoms of these cancers. Maybe you can take about the gallbladder, pancreas, CBD, or the liver ones. Yes, please.
So most of the time, patients do have symptoms. You know, when you take gallbladder cancer or pancreas cancer, abdominal discomfort, weight loss. They go to the doctor. They find some abnormal blood tests, such as change in the liver enzymes. Uh, these are sort of the more common symptoms for most of upper GI cancers. Specifically for pancreas cancer, recent onset of diabetes, change in bowel habits, indigestion, abdominal pain in the upper abdomen or back, uh, asymptomatic jaundice. Sometimes people just turn yellow without any other symptom. So these are some of the symptoms that should alert the patients and physicians that something is going on. And of course, there are many non-cancer causes of these symptoms. So, the best thing to do is first start with your family doctor, get examined, get blood work, and particularly if the symptoms don't resolve, persist at it. Too many patients actually seek medical attention and are still not diagnosed at the right time, and a long time goes before the appropriate diagnosis is made. So if symptoms are not settling down, then don't accept it. You might need to talk to your doctor again, or even get another opinion, because these days with modern, some of these symptoms would alert your doctor for imaging, like a CAT scan or ultrasound, and it's not that difficult to spot anymore.
So, Dr. Milind, you have actually summed it up very nicely. One of the challenge that we see here that because I think that we are picking up sometimes the cancer, the subtle manifestations in the blood test, and not the symptoms, symptomatic manifestations. But the problem here is that especially the elderly people, the practice of doing at least a annual yearly blood examination or some kind of investigation just to see how the body is doing, that practice is still not there. Maybe just 0.5% or 1% of the population. But the whole awareness, that the health awareness part, I think, is missing. And people have to understand that after a certain age, especially, it's very important that you test yourself, because not just the diabetes or the other problems or the cholesterol that you pick up, maybe the subtle signs of cancers are also picked up, isn't it? So,
Absolutely. I would say I don't want
how
to
is it
advocate.
there in the US?
Well, there is an emphasis on prevention.
Okay.
And so to try to get an annual physical examination and blood work, unfortunately, not everybody does it, Priya, just like in India, but they certainly have access to it. And
Okay.
I think the same
That's
can
important.
happen in India,
Yes.
where not everybody needs to get a blood work and ultrasound every year, but they need to see their family doctor on a regular basis, get a good physical examination, and be attentive to symptoms that don't go away or symptoms that are unusual, because that would alert you that something else is going on and lead to blood work. Unfortunately, there is sometimes no substitute for blood work. I mean, we find a lot of patients with cancer who have no symptoms and have had blood work for a cholesterol medicine or for, just a routine blood count and chemistry, and find something wrong. So I do think there is some merit in annual exams and annual blood work, especially after middle age. But at the very least, an annual physical examination, talking to a doctor will help us find something earlier.
So I think that is the message that should go to the audience very clear, that yes, please focus on your health and the examination part, the physical examination, and also if you can do certain blood tests, then that will be, I think, fill some part of the gap that we are trying to address today. You also highlighted a very important point, Dr. Milind, that was the recent onset diabetes. So whenever we see a lot of diabetes now in India, and it's also because people are living longer, so we are seeing a lot of these problems that we see more with with aging. So important thing is when you have a diabetes. So when you have a recent onset diabetes, that means something is wrong with your body metabolism, and there we see more cases of pancreatic cancers, because cancer is essentially a disease of some abnormal body metabolism going on. So yes, at that time, maybe a general checkup, and just to be increase awareness and the increased suspicion for pancreatic cancer should also be done, isn't it, Dr. Menon?
Yes. So,
Uh,
Priya, I mean, India, unfortunately, here I see the Indians as well, epidemic of diabetes. A large number of Indians are being diagnosed. Um, but there's what I think better, 20,000 or 25,000 pancreas cancer patients in
yes, still
India.
less compared to West, I would say. Yes.
Still less than compared, right? So the actual number, that it's a very small fraction of
Yes.
recent onset diabetics who will have pancreas cancer. So I think, but anyway, if there is a recent onset of diabetes, a good idea to see your doctor, get a full physical exam. That person will ask you some questions that can alert to symptoms, like is there any upper abdominal pain? Is there any bloating, gas, indigestion when you eat food? Is there any malabsorption symptoms, for instance, diarrhea or intolerance to certain fatty foods? Things like that in association with diabetes or alteration of liver function tests will alert to the diagnosis of pancreas cancer. But it is rare, and I don't want to over investigate for a disease that is uncommon. But it is unfortunately a very fatal disease for in most instances. So, you know, community doctors should be aware of that possibility when they see a new diabetic patient.
And we are often asked a question from general physicians that whenever somebody comes with an unexplained weight loss, when should we suspect cancers? So it's a very common question that we get from them because we understand that the unintentional weight loss is also a symptom of cancer. And the usual question they ask, ma'am, should we get a PET scan, a CT scan directly whenever we get an elderly male or female with an unintentional weight loss, or what should be done? So, any thoughts about that?
So I really think that I was recently in India and I was amazed at the good quality of medicine like that young people like you, Priya, are delivering. But I also find sometimes that there's a little bit over investigation with, for instance, with PET scans. So I would say if there is someone who has an unintentional weight loss, there are many other causes besides cancer. For instance, it could be just old age, it could be depression, it could be thyroid, it could be diabetes. So I think at the very least, a good interview with your doctor, some routine blood work might be enough to find the cause. And if this continues, and if this is not explained by physical signs, symptoms, and laboratory work, then yes, we will need some more imaging.
Yes.
But to be cost conscious, I wouldn't recommend a lot of imaging right away. I think that India is really so good at clinical history and physical examination. This is an art that is disappearing in the West. So I think we should still rely on that to have a good interview with the doctor and just lab work, and then decide at that point if we need anything more.
So I think health awareness, get educated, get your annual examinations done, and yes, if your doctor order certain tests, go ahead with that. Then
Absolutely.
yes, that's the way. I think that's the right approach. So just to take this discussion forward, the pace of research has been quite slow in these cancers compared to many others, and especially the advancements, the treatment advancements. You can correct me anytime, Dr. Milind, if you feel that I'm speaking something that you don't agree with. And but I feel that maybe it has been slower, and the advancements have been like lesser compared to many other cancers. But yes, there are pointers which are contributing to improving outcomes. Just can you highlight some of them?
So, Priya, I've been working on this field, like, for instance, bile duct cancer now for almost 16 years, right?
Okay.
And prior to 2020, we had no approved drugs other than gemcitabine, 5-FU, like really old chemo drugs.
Chemo drugs,
So
yes.
now, in the last 4 years, we have five new drugs approved.
Oh,
So
five
actually,
new.
the pace is quite exciting.
Oh, super.
Our priority now is to try to get these drugs and new advances to our patients in India.
Yes.
And we're going to need to collaborate with, physicians, with industry, with scientists to get these advances. But in pancreas cancer, on the other hand, it has been less so. I mean, we are, still working on some of the chemotherapy regimens that we used, several years ago. So in that instance, early detection, surgical management, these sort of non systemic therapy approaches are going to make strides. So the pace of progress is still not as rapid as I would like, but it's been actually fairly remarkable in the last few years. So I'm hoping through meetings like this, we can collaborate with our partners in India, partners in science, partners in pharma, and first of all, get these advances to people there, and then also develop a strong R&D infrastructure in these countries where the diseases are more common, so we can have an impact. So I feel hopeful. If you just treat pancreas and biliary tract cancer for 15 years, you got to be hopeful. And I'm just,
I realize you're a very optimistic person, isn't it?
I am, and like you are, Priya, otherwise we wouldn't do our job, right?
Yes.
And I feel like we have to for our patients. And I think I do actually see a lot of changes that I didn't see before over a decade ago.
So I think also because the practices around the world has been changing together, in the sense like all the cases are now being discussed in the tumor board to decide what could be the best plan of management. And now the tumor board discussions are also picking up in India. So people are coming together to discuss what should be the best line of management in the patient, rather than just one kind of specialty deciding about the right kind of management for the patient. And also for the pancreatic cancer, Dr. Milind, tell me, is it like at some point of time we were just doing surgeries if we felt that the patients are just resectable, but now every patient should undergo some kind of pre-operative treatment. And yes, that is how the pancreatic cancer outcomes are changing. And also the surgical expertise part means the high volume centers are doing better than the rest of the world. Is it like that?
Yes, I think you touched upon several points. I think
Yes.
these treatments are truly multidisciplinary. They include
Yes.
surgery, medical oncology, radiation, prevention. And the one good thing that has come out of COVID is the world has become a smaller place. So
Yes.
we are now having these multidisciplinary meetings all over the world, and I've participated in these meetings, in India, in China, many other countries. So I think we are together able to attack these cancers.
Yes.
I totally agree with you that it is possible that through early detection, through multidisciplinary forums, we can make an impact. Now, going to pancreas cancer, which you mentioned, we believe now that even if the cancer is localized to the pancreas, it's actually a systemic disease. That is,
Yes.
it may be in our DNA, it may be in our bloodstream. So we do treat these patients preoperatively, and postoperatively with chemo, sometimes with oral medicines like olaparib and immunotherapy in some instances. So there are many approaches, not just one.
So, for our audience, Dr. Milind has told a very important statement that the localized pancreatic cancer is also a systemic disease. By that, it means that the cancers has tendency to spread in the body through various channels, especially the blood stream. So, once the cancers goes in the bloodstream, we call it as a systemic disease and not just a localized to an organ. So there are certain cancers, like rightly pointed out, in the pancreatic cancers, which have a very high tendency to go in these process of dissemination very early in their course of starting the disease. And that is why it's very important that you have to address both the aspects, the localized part also and the systemic part also. And that is why we want to go very aggressive about it. And that is why the whole, what we call medically, the neoadjuvant treatment approaches, that is where the world is going, especially for the pancreatic cancers. So they're telling, can we take some of the audience questions? Should we? I think we can. Isn't it, Dr. Milind? We have got many.
Sure.
Yes, okay. Why is liver cancer? Oh, yes, we did not discuss liver cancer in detail. Why is liver cancer so dangerous?
So because with liver cancer, you actually, teach my fellows, you're treating two diseases. One is the cancer itself, and the second is the underlying liver. So often patients who get liver cancer have liver disease with hepatitis, cirrhosis from alcohol or fatty liver or so on. So sometimes the medications that you need to treat the cancer with cannot be delivered because the liver doesn't work well. So it is dangerous, but I am optimistic. A lot of strides have been made, particularly with immunotherapy. And now immunotherapy is used for, standard in liver cancers, where we treat patients with advanced disease, sometimes preoperatively with immunotherapy. Now a study showed postoperatively. So this paradigm is changing. But to truly change this, we have to try to impact on hepatitis B, hepatitis C, alcohol, and obesity. And that will also happen.
So a very important point here is that for many people, it must be like a new thing that even infections can cause cancer. But yes, this is what it is. The hepatitis B, hepatitis C, they can cause liver damage, which over the period of time can give rise to cancers. So hepatitis B vaccination, that is why is recommended also, because you can prevent the hepatitis B virus infection, and you can also prevent the cancers associated with it. But I think unfortunately the usage is very less in India, and I'm not sure how much is the usage there in the US. Obesity we talked about is a very important risk factors, and so is the alcohol, and no amount of alcohol is safe. So the liver cancers are dangerous because you have to treat, not take care of not just the cancers, but also the bad liver. So there are just two problems which are happening, and they'll be complicating each other management, and will also be compromising the life expectancy, isn't it, sir, Dr. Menon?
Absolutely. I think
Yes.
you said it very well, Priya. I don't have to add more.
Thank you. Yes, so the other question is, dear sir, ma'am, first time greetings from me. Patient is my father, 78-year-old gentleman. He has been suffering bile duct carcinoma since Jan 2021. In that time, ERCP stenting done in between CBD and CHD. After that, he is taking treatment from an oncologist and a gastroenterologist. So we do have a multidisciplinary management there. Presently, patient has taken tablet regorafenib, 40 milligram, two tablets daily morning. So that is 80 milligrams, I think, per day. Second cycle continuing. Patient has no chief complaint. Now I would like to know this medicine tablet regorafenib, how much effective for bile duct cancers or gallbladder? It's less used medicine for these particular indication. Dr. Menon, your thoughts?
Yes, you're right, Priya. It's first of all, I think just like liver cancer, you deal with two things here. One is biliary obstruction, and second is
Yes.
the cancer. So I'm
Yes.
very glad you have a good gastroenterologist who is doing stenting, keeping the biliary tract patent and free of obstruction. Regorafenib is one of the options, which it's not, I would say, the most commonly used option. We use gemcitabine, cisplatin nowadays. An immunotherapy called durvalumab was approved in the US, and there are other chemotherapy drugs. Durvalumab, regorafenib is one of the drugs.
Mhm.
If your dad is doing fine on this therapy, I don't think we need to change.
Agreed.
But
Definitely.
you can leave him on that, but also keep an eye on other options. Talk to radiation, for instance. Is there any other possibility of local therapy? um, and we have to scan every couple of months to make sure that things are on track.
Yes, agreed. So the whole idea is that if the patient who has advanced cancer, if that patient is doing well on any particular therapy, that means the symptoms of the disease or the treatment should not be there. The treatment related toxicity should be manageable. And if there is, like the symptoms are improving, and maybe like rightly said, if the scans are responding, you can do certain blood markers evaluation also. And if those things are improving, then yes, that's the right way, isn't it?
Yes,
Because we
absolutely.
have to use all the options very judiciously.
Yeah. Make sure your dad has a genetic testing if they can,
Yes, that's very
if they
important, genetic
do,
testing.
to see
Dr. Milind,
what kind of.
please, yes, just elaborate on the genetic testing part. It's very important. I don't think so the audience knows much about it.
Sure. So I'm going to divide that into two types of genetic testing. Okay. One is what we call germline, or a gene that you can inherit from your parents. For instance, there's the breast cancer gene, ovarian cancer gene, can have also bile duct cancer, gallbladder, and breast and other cancers. So that is germline testing, tested in the blood or in the sputum. And the second is a gene that is abnormal in the tumor, that is called somatic genes. For instance, dad had this bile duct cancer. If there's a tissue sent for genetic testing, we can test what genes there are and see if there's a targeted therapy that is specific for those genes. So some of the drugs that I mentioned to Priya earlier, 5 approved drugs, out of them 4 were actually targeted therapies approved for bile duct cancer. So there is a lot of merit in getting those sort of testing and that type of testing, and it is possible. Patients often ask me that, look, I have this IDH mutation, one of the genes in the bile duct. Will I transmit it to my children? And that's not the case. This is a gene in the tumor. That's not germline. So there's inherited gene and
Yes,
tumor genes. And there's good ways now. India has really very good technology to
yes.
test both of those genes, and they might have they may create more opportunities for treatment.
So I think Dr. Milind, you have summed it up really nicely because the audience, I think it's very important to point out what are the tissue-based genetic testing that we are doing, and what are the germline testing, which are like the heritable mutation we are trying to detect. It's very important to understand the difference. Also, in because the patients are also becoming aware in the OPD, we are often asked the questions: what is the difference between chemotherapy, targeted therapy, and now latest in this is the immunotherapy. So maybe you just touched upon it. Just maybe you can just sum it up all once more.
Yeah, so chemotherapy is medicines typically given intravenously or in a pill form.
Yes.
And these are medicines that damage the tumor DNA. You know, they typically act on rapidly growing cells like cancer cells, but they
Yes.
also act on other rapidly growing cells like hair or mouth oral mucosa and other cells that turn over. So it has other side effects, but it acts on DNA. Targeted therapy is therapy that is targeted towards a specific gene that you find either in the tumor or germline inherited. So it's targeted to a specific gene. And immunotherapy is medications typically given intravenously, which increase your own immune system, which to increase your T cells in the tumor or immune cells in the tumor to fight the cancer. So this immunotherapy has been a truly revolutionary change in the last 2 decades in the management of these cancers. One of the pioneers at my institute, Dr. James Allison, and his wife, Pam Sharma, they have really been the pioneers in this field. Some of these medicines are now making it into India, for instance, in biliary tract cancer as well. But I think that there are now many options besides chemo that are useful for patients.
Good for patients. So just to sum it up, the chemotherapies are more of non-specific in their actions, and the targeted therapies are specific and they do directly the cancer killing. The immunotherapies, they work indirectly to achieve cancer killing via the some kind of body's immunity, like you said, the T cells mediated. There are various kind of body immunity which take part into cancer control and fighting the cancer cells, and the T cells are one of them, and the immunotherapy works via them, and we are seeing the remarkable results, as Dr. Milind already said. Yes, a few more questions. My grandmom, age 75, diagnosed with pancreatic cancer, which has been metastasized to liver and lungs. Should we go with the palliative care or standard of care? Patient, a very important point of discussion. People are, it's always a very difficult decision. What should be the line of therapy for a particular patient, especially elderlies?
Yeah, so I
Because
think,
everybody is fearful of the word chemotherapy. Yeah.
right. I mean, I think you'll have to talk to your grandmother and see what her wishes are. If the cancer has gone from the pancreas to the liver, it's treatable, but it's not curable. And
Yes.
its survival is people survive for anywhere from 8 months to 1.5 year, typically not much longer. This comes at the price of some chemotherapy. The chemotherapy in this cancer is supposed to be palliative. That is, it helps people feel better, control their symptoms, not just that chemo makes them sick and lose their hair and that sort of thing. So I think it's worth considering. I mean, I regard 75 as not very elderly. I think if your grandmother is in good shape, if she wants to consider treatment, then it's worth considering. But do make sure her goals are kept in mind. The chemo is not going to cure; it's going to control. It's going to buy some time, and it is going to have some palliative value. The other option is not to do some chemo, focus on quality of life and comfort, and that is appropriate if that's what the patient wants. But that too comes with a price. You get symptoms, you get pain, you get biliary obstruction and discomfort, and that sort of thing.
And maybe you can do just genetic testing there and find out certain targets or whether if the immunotherapy works or not, isn't it?
Definitely, you
That is
can do
definitely
genetic
can.
testing to see if
Yes,
there's something inherited that can be targeted.
yes,
You can see if immunotherapy works
yes.
in a small number of pancreas cancer, but it can.
Dr.
So
Malik, but yes, please. I'm so sorry. Yes.
no, it's fine. I think that's all I
So
was going
I
to
was
say.
just trying to bring a very important point of discussion here, Dr. Milind. It's very common in India not to tell the patient about the diagnosis, and even if the diagnosis is shared, the extent of disease is usually not revealed.
Yeah.
It's a very common practice.
Yeah, Priya, and it's a common practice here. I see some Indian patients, and I saw an Indian lady from New York who came to see me in Houston, an educated person, and her husband said, "Don't tell her she's got cancer." And I said, look, I mean, first of all, she's come to MD Anderson Cancer Center. Don't you think she
Yes.
saw the label? And then if you were in that situation, wouldn't you want to know
Yes.
what you have so that you can plan your life? So I think it's a traditional thing, not just in India, but in many cultures, where you don't let the patient suffer with bad news. Let me deal with it instead. Well, the reality is that patients are more resilient. They're stronger than
Agree.
you think,
Yes.
and they may be able to deal with it better than you think. So, and if they have a limited amount of time, maybe they need to take care of some matters. So it's best to be upfront and honest.
So it's a very accurate thought, and I echo your sentiments, Dr. Milind, completely. Because everybody, I feel that yes, like you said, people are more resilient, and maybe our elderlies are. Maybe we are just underestimating their own mental and the physical mental resilience, especially. And yes, everybody has a right to know about their diagnosis. Yes.
Absolutely. I think we have to use the same metrics that we use in day-to-day life
Yes.
as we
Yes.
use for our health. We are not going to buy something from the store without
Yes.
knowing its price. So similarly, we are not going to get a treatment without knowing what we are getting treated for. So I think you'll be surprised if you actually let the patients know there is some time of grieving and so on, but then they
The
have your
initial
love and their
phase.
support
Yes.
and they can get
Yes.
over it.
Yes, yes. So I think I'm glad that we discussed this aspect too, because
Yes.
everybody needs to hear this, and we need to maybe make some kind of paradigm shift in how we approach the our loved ones who are having cancers, because this is very important to understand that the mind frame also works well, and it helps us to find a support system, and it improves the sharing part also, because the patient, many times what happens that the patient and the family will never have an open discussion regarding the diagnosis itself. So we
Yes.
just, yeah, a lot of time and the energy is spent in just hiding the information, and that I think somewhere also compromises the bonding and the care as well, isn't it?
Yes. So actually, I tell my patients that uh, for the first visit, if you don't want to talk about it, it's fine. I want you to go and discuss it at home, but I can't continue treating your loved one if they don't know the diagnosis. And 100% of the time, really, it has never happened that because of that they would not no longer come to treatment or come to see me or something. uh, they need their time, and I think 100% of the time it has always worked where the patient and their family have continued with their treatment with a better knowledge so that
Yes.
the patient can educate Priya and educate me according to what their wishes are,
Yes.
so we would follow those considerations when devising a treatment.
And yes, and we have to respect that totally. Um, so very important question. Hi, good evening. I am from Bangladesh. My father suffering from bile duct carcinoma since 2020 June. Age is 79 years. So yes, like we discussed, the cancers we are seeing in all elderly patients. By diagnosing this disease, then ERCP stenting done. After that, he has taken tablet capecitabine 12 cycles, which is oral chemotherapy. His CA 19.9 sometimes downtrend. Now CA 19.9 is 1350. Dr. Menon, I would just want you to touch here after this tumor markers also. I think we did not touch them. Maybe just a brief about that. The patient is taking the CA 19.9 is sometimes showing downtrend. Now CA 19.9 is 1350. Presently, again, tablet regorafenib is taking. Third cycle continue. Patient is stable, no abdominal pain or complaint, able to eat sufficiently. This is lung is weak due to COPD oblique ILD. Now I would like to know how much effective tablet regorafenib for bile duct cancers. Please advise. Thank you.
Yeah, so the one thing, so for the audience, I would say CA 99 is a blood
Yes.
test, sort
Yes.
of like a PSA for prostate cancer. CA 99 is elevated in 80% of patients with bile duct cancer and pancreas cancer. It is a good reflection of the cancer progression, but it's not a 100% test. So, for instance, if someone has an elevated liver function test, then the CA 99 can go up even if there's no cancer. So I don't rely on that completely. I see a trend now as being more meaningful. So if your father has a CA 99 that has gone up, but the scan looks stable, he's doing fine on regorafenib, that would not be any reason for, in my view, to change treatments. We can stay on the same therapy. Regorafenib is a more stabilizing drug. That is, when it is used in the second or third line, that's where we use it typically in the West, some chemo first. Then it can control the disease or stabilize it for anywhere from between 3 to 6 months. That is an average. It's, of course, some people do much better, and your father seems to have a good history because he's been on Zalora for all these 10 cycles. So he may get better benefit from regorafenib. So if he's feeling fine with it, irrespective of the CA19-9, as long as the scans are okay, we can just stay on that therapy.
Um, what's happening here in India is that patients are so a lot of labs are just they are making the whole what is called as the blood test packages, where you have complete blood count, liver function test, kidney function test, lipid profile, HbA1c, and they're also including the tumor markers there. And we are getting a lot of patients simply because of the panic that they have done. Just in the package, CA 19.9 was included. The upper limit of normal is around 37, and it shows 42, 43, 44. So a lot of patients we are getting, a lot of healthy people we are getting because of this particular reason, because of this panic part. So
Yeah.
people have to understand that sometimes there could be just unrelated causes for transient elevation of these tumor markers. And it's important for the healthy people that you understand and not panic, isn't it, Dr. Milind?
Yeah, Priya,
Is it practice there
I
also?
remember it's true. I mean, what I remember being taught in early years in residency, that don't order a test
Yes.
if you don't know what to do with it.
Simple.
So,
Very simple.
some of these markers, like Priya said, can be elevated with many different things, not just cancer. And then you start chasing your tail with a lot of unnecessary tests. So I don't recommend that. I would recommend routine chemistry, blood work at physical exam, not tumor markers, because that's not a good way to screen for cancer.
Yes. Very important, very interesting question. Any advice for the Indian government policy makers for these cancers?
I do actually. I do think that uh, besides the obvious, right? Cancer screening guidelines and healthcare checkups, focus on prevention, right? More money on prevention and early detection. The area, my selfish area to work would be also in gallbladder cancer. That if we have a program where you can't have a screening program for a cancer that's not that common, but a program that includes education, a program that includes high quality surgical resection without complication by a skilled cadre of surgeons. Uh, I think that will help us actually impact this disease really within the next 20 years. And the availability of skilled physicians such as
Yes.
yourself to be able to deal with and treat it. I do think we can impact it measurably in 20 years because that's what's happened in the West. A lot of this disease is going, and that can happen in India because too many young people, young women, are diagnosed with gallbladder cancer.
And unfortunately, many of them just die.
Yes, many of them succumb.
So I think that's a very important aspect to it, that yes, maybe we just train group of surgeons for the high quality surgeries
Yeah.
where we don't have surgery related complication, and yes, you end up removing the gallbladder and ultimately preventing the cancers.
Yes, and education,
Edu-
awareness in the community,
yes,
so that
yes,
people having pain and symptoms of
yes.
cholecystitis get access to good
Yeah.
quality surgery.
Yes, so I hope the government is please listen to this. It's very important because that will be it will be milestone in preventing the cancer related deaths, especially gallbladder. Because the problem is we are losing the economically productive population to gallbladder cancers, because a lot of gallbladder cancers, like you said, that yes, it's happening in
Yes, young women, young mothers.
young mothers. Yes, I see more questions. We are getting questions from all kinds of cancers now, but we'll just limit ourselves to the point of discussions, to the discussion pointers that are we will just focus on the pancreatic or biliary cancers. Rest of the questions, like there are questions from the duodenal cancers, breast, oral cavity cancers, you can just mail us, and maybe we can take a reply on the mail itself. And Dr. Milind, I just wanted you to also touch upon the this aspect of clinical trials. So important thing is now we also have a like Indian trials in India also. We had durvalumab trial in our own hospital actually for the biliary tract cancers. So I want you to bear the what kind of trials do you have, and also are there any trial open for the Indian patients who can just like go there and get enrolled?
So certainly, we have a lot of trials in the US, a lot of trials at my center. But I'm really hoping that we can open these trials or really have young people like you and others open these trials in India. So the typical process, for instance, for young faculty, when I studied in the US, is to learn how to write a letter of intent, to write a clinical trial protocol, get pharma engagement, get National Cancer Institute engagement, get funding, open the trial in many centers, have these trials access, have patients access these new drugs, which they wouldn't have otherwise received. I think that infrastructure is very much feasible in India, and I think we should do it. I work closely with my partners in China, and this didn't exist there 10 years ago. And a lot of these trials are now opening there. India has a huge pharma industry, and I hope that many of them will now get into oncology and invest into the clinical trial space, because I think that would have a lot of benefit for our population, a lot of benefit for pharma industry, and a lot
Yes.
of benefit for us. There are these cancers, just because India is now the most populous country,
Yes.
we will have a lot these trials done quicker there, and we can learn from those trials, and we can apply them all over the world. So I hope that the country, the government, and academia, pharma makes it a priority. I'm going to make it a priority for sure that if there's a trial I'm engaged in,
That will be great.
should we open it in India?
Yes, because the important thing is there's still a lot of resistance among people regarding when the travel trial comes, because they feel it's kind of experimentation, because people are usually not aware about what exactly the trial means. But and in the process, sometimes they don't get the benefit of a very good drug, a very effective drug. So also the purpose of asking this question to you, Dr. Milind, is because I want them to get over this shyness or this hesitancy that they have towards trial, and realize that yes, they can get benefit of very important therapies that are being, and the latest in the research which is being offered. And yes, like you said, we are seeing more and more pharma companies bringing the trials to India.
So one of the things I tell patients is that, look, you're afraid that you might get a placebo or a sugar pill and not get actually cancer treatment. That doesn't happen in oncology,
Yes.
because patients have a difficult diagnosis, have a limited survival.
Yes.
If they are randomized, that is given one arm, the other, it's usually either a standard treatment that they would have received anyway, or an experimental treatment, which we hope will be better than the standard.
Yes.
So you don't lose anything by
Yes.
participating in the trial. And patients on a trial are managed actually better, because they are
Yes.
very carefully managed with labs. Everything is managed in a very perfect way, for because these charts are eventually audited and looked at
Yes.
by many people. So there is nothing lost, and I think there is plenty to be gained by participating in a trial. I would participate in a trial if I were a candidate, and that it is important that you also understand these trials go to ethics reviews.
Yes.
So we can't just pull any drug out of the air. It has to be reviewed by a lot of people to make sure that this is actually a good option to consider. So the risk is actually quite low now in the participation.
Yes, so it's very important that people should understand the purpose behind the trials, the benefits associated with it, and they should also understand that the channels through which the trials come. I think we are done with all the questions and the major part of discussion. It's a never-ending topic in the sense there are many aspects and the many facets to it. But I think that will be all.
Thank
Yes.
you, Priya. For the audience, I'm available to you. I'm a GI doctor, so I wish I could help you more with head and neck and breast, but I probably won't be a good person for that. But if I can be of any assistance, don't hesitate to reach me. I'm also on Twitter. And I really want to thank Priya and our sponsors for making these sort of meetings possible and allowing us to reach a larger audience in India.
Dr. Milind, you have no idea that yeah, what kind of information you have given to us. It's mind blowing and awesome. I would to put it simply, in the sense because bile duct cancers, gallbladder cancers, pancreatic cancers are usually not discussed with audience on a platform, and especially with an expert like you. I think this is like first of its kind discussion that we are having in India. But this is, like I previously said, a much needed discussion, because for many of the audience, I can ensure that must be eye opening for on the various aspects of these cancers. And yes, the discussion has to start but not end. It's an ongoing discussion, and maybe we'll again have a discussion with you after, if we get questions. And yes, people will be trying to reach out on various platforms, as you said.
Thank you.
Thank you, thank you, thank you, Dr. Milind.